Good afternoon. I trust you can see my screen.
Yep.
Great. Well, thank you for inviting me, and I'm going to spend the next about 45 minutes talking to you about an update with COVID and a little bit more I'll tell you about in just a moment. Um, anyway, I'll save a lot of time for questions, so please hold your questions to the end, but I'm happy to take any questions you have. And also, I wanted to reflect on the fact that I had the honor of speaking to the Ashby Village on the same topic in 2023. So the agenda for today is, first I want to talk about the state of the pandemic, and then about variants, and then about diagnosis, treatment, prevention, and I'm going to actually spend a considerable amount of time talking about vaccines and vaccine policy. So that'll be my agenda for today. But again, feel free to ask any questions about this topic you would like, or any topics in infectious diseases. All right. One second. I'm unable to advance my slides. Let me try it one more time. There we go. So let's first start about talking about the state of the pandemic. All right, so this is our agenda, and let's start with the state of the pandemic to just give you a sense of where we are. And this is good news, tucked in a little bit of tentative news, but it is good news.
This from Microsoft PowerPoint. Continue to share this PowerPoint window.
COVID deaths in the United States from the beginning of the pandemic over on the left-hand side of the screen, all the way over to the right-hand side of the screen where we are today. And I just highlighted a few points in terms of the highest point of deaths it was in early January of 2021. We were having roughly 25,000 Americans die every week from COVID. In the following year, in January of 2022, we were having about 19,000 deaths at its peak, dying every week from COVID. And as you see over on the right-hand side, the highest peak for 2025 occurred in January and was roughly about 1,000 to 1,200 deaths per week. Currently, well, we don't know exactly where we are currently because our data is very delayed, and I'll speak about that later. But we're ranging somewhere between 100 and 200 to 250 deaths a week from COVID. Now, that's still tragic. That's 200, 250 people who would have been alive if this virus hadn't entered our population. But it's quite a difference between what's occurring now and what we experienced in January of 2021 and January of 2022. And so that's really good news. This just looks at where COVID was in 2019 when it was the third leading cause of death. Actually, for a while, in 2020. For a while in 2021, it was the leading cause of death. And in 2023, it had dropped into the number 10 leading cause of death in the United States, and now it's not even in the top 10. Still causing deaths, but nothing like what we experienced. But it still carries considerable morbidity. This is data from the CDC that I think is reliable, and it's based upon data from the end of September 2024 to August 2nd of this year. And these are all projections, they're all estimates, but you can see where it accounted for millions of illnesses, lots of millions also of outpatient visits, hundreds of thousands of hospitalizations, and still a considerable number of deaths. Let's look at deaths a little more closely. I put this together to give you a sense of COVID deaths in the United States. In the year 2020, we estimate around 380,000 deaths. Americans died of COVID. This is just America, 4% of the world's population. In 2021, there were about 417,000 deaths. In 2022, almost 190,000 deaths. 2023, about 50,000 deaths. 2024, 47,000 deaths. And we don't really know where we are right now. The guesstimate is we're probably going to come under 50,000 and maybe by closer to 40,000 or even the high 30,000s. So clearly the number of people dying from COVID is better. I put at the bottom just to give you a sense of comparing this to influenza. We average somewhere between 12 and 52,000 people dying every year from influenza. This year was a particularly bad one, and we had about 35,000 Americans die of influenza. A year or two before that, we had around 12,000, 10,000 people die of influenza. So COVID remains a major cause of death from respiratory disease that visits us every year or twice a year or more. And it is still causing more deaths from influenza on average, but it's starting to approach the number of deaths caused by influenza. To get the best idea of where we are right now, we can look at what the CDC calls early indicators. That's what's called test positivity, the number of people who get a test for COVID and are reported as positive. This is not very accurate because most people are testing at home and they don't report their results. But for people coming into a healthcare facility, it's relatively accurate. And you can see that where we are today compared to a year ago is still appreciably lower than a year ago. But you can see that we're continuing to increase in terms of the numbers, the percentage of people test positive. And emergency department visits next to that also shows a steady increase over the last several weeks. This is data up until August 2nd. You can also look at what are called severity indicators. Those would be hospitalizations and deaths. For hospitalizations, the numbers are increasing, but not nearly as rapidly as the people going to the ER and testing positive. And deaths are slightly increasing. But you'll also notice that for hospitalizations, the data is through July 19th. It's almost a month old. And the data for deaths tends to be, there's a lag of about 4 weeks between the time somebody dies and the time it gets reported. So it's a very lagging indicator. So I think bottom line is, well, I'll tell you what the bottom line is in just a moment. I wanted to just mention that in talking to my colleagues at Alta Bates Hospital in Berkeley and Summit Hospital in Oakland, they are seeing more ER visits in the last couple of weeks, and they're seeing more hospitalizations in the last couple of weeks. So we've been on a steady increase in the number of cases throughout much of this summer, but we're still lower than we were in terms of the number of cases at its peak last summer when we had a late summer peak. If we look at the wastewater data, this is where we find the RNA of the virus in the wastewater. You see California is in the high category, as are several other states, primarily in the west and south. One state in the south is in the very high category. That's Louisiana. And also Hawaii is in the very high category. So there's a lot of COVID virus still circulating here in the US, and the West seems to have a higher amount than many of the other states in the United States right now. I also wanted to point out in terms of where we are is the impact of COVID on children. A lot of people are saying incorrectly that this is not a serious disease for children. It is correct that children don't die nearly at the rate of adults, but frankly, children don't die nearly at the rate of results from most things, particularly older adults. So I listed four things on the right-hand side of the slide that I wanted to bring to your attention. First, the hospital rates for children less than one are like those between people between ages 65 and 74. You hear a lot of talk about people over 65 are at higher risk for morbidity and mortality from COVID. Well, children less than one are in that same category. There's a disproportionate number of children less than 6 months who have died from COVID. About 50% of children more than 4 years of age who were hospitalized or died from COVID were otherwise healthy. So it's not, when you hear people say, well, they probably just weren't healthy children, that's not the case for over half. And COVID accounted for about 3% of the emergency room visits in California in children who were less than 11 years of age. And that's triple the rate from 1 month ago. And it's the highest for any age group. So lots of children are still experiencing COVID and sick enough to go to the ER, some enough sick enough to be hospitalized, and some enough sick enough to die. So bottom line for where we are today, we are in a wave, not a surge. I try not to use the word surge for where we are in an increasing number of cases because that brings our minds back to 2021, 2020, 2021, 2022 when it was these surges were devastating. We're not in anything like that, but we are in another wave. We had a wave last December, January, and we're having a wave now. And going forward, nobody knows how this virus is going to evolve. It could revert to a form that is more virulent again and cause lots of deaths, but I think that's highly unlikely. I know we're going to continue to see COVID. I know that it's going to be with us for a long, long time because it's endemic not only in humans but in animals, so it's going to continue to circulate. But I also know that almost everybody in the United States and probably around the world now has some degree of immunity to COVID. They've either had COVID once, twice, 3 times or more, or they've been immunized, or a combination of those two. So we're not in the same place we were in December 19 when no human being on this planet had immunity to COVID. So we are in a better place. So that's what I wanted to say about the state of the pandemic. In terms of the variants, there are several circulating, and I'd like to talk to you about those because you've probably been reading in the paper about them. But before doing that, this just shows you how this virus has evolved from, on the left-hand side, what we call the ancestral strain that no longer exists and didn't even get to the United States before it had changed to what's called D614G, which caused the initial waves and caused a lot of deaths. Those terrible pictures in my mind still of New York City in the spring of 2020 with the emergency hospital ship to take overflow and trucks that are refrigerated trucks to store bodies, people in the hallways on ventilators because there were no rooms for them and so on. So you can see how this virus has evolved to epsilon and alpha again, and then delta. And then in December of 2021, Omicron reached our shores. It was first identified in November of 2021 in South Africa. And since then, we've been in the Omicron pandemic. It's been the Omicron version that's been slightly changing, what we call slightly changing is probably the best way to say that, continuously since then. So that's where we've been. We've been in the Omicron pandemic now for almost 4 years. And these are the different strains, and I just want to take you through this. I'll show you what to pay attention to. Here's the original strain of Omicron. And it evolved to, and what we saw last year causing a lot of disease was JN.1. And then JN.1 evolved to KP.2, which continued to cause a lot of cases last year. And the vaccine from last year was based upon JN.1 and KP.2, and that's the vaccine that's continued to be given. But the virus has continued to evolve. One of the strains that it evolved to is NB.1.8.1, LP.1, and XFG. So the reason for showing you this is that you can see that all of these, NB.1.8.1, XFG, KP.2, LP.1, these are all derived from JN.1, which ultimately was derived from the original strain. And that becomes important in terms of strategies with vaccines that I'll speak about later. This looks at the virus in terms of these subvariants that have been evolving from March of this year to most recent data, which was June 21st. Now, last year, we had up until about January of this year, we would have had data from just a week ago. But the data we have now, the most recent data we have is from June 21st. And the reason for that will become apparent towards the end of my talk. But the three sort of gorillas in the room that are causing almost all the disease are LP.8.1, which is very similar to LP.1.8.1. The NB.1.8.1 or Nimbus, and XFG, also called Stratus. Now, the Nimbus has the highest binding affinity, meaning it can bind to our cells better than any of the previous Omicron strains. And Stratus has the ability to escape our immunity better than any of the previous strains. So these are the selective advantages to those two. All of these are called variants under VUM, variants under monitoring. And so we're keeping an eye on these. You'll notice at the bottom, the CDC has a disclaimer that the low number of sequences reported is due to the fact that they're not collecting enough samples, and I'll explain that later. So when you read in the papers, these are the three that we're concerned about right now. They are no more virulent. That is, they don't make us any sicker than any of the previous Omicron strains. Excuse me. So, and they remain detectable by our current diagnostics. You may have read about razor blade throat that people have described. All of that data is anecdotal, but in terms of good studies, we haven't seen any evidence that these strains make you any sicker than any of the previous strains that we've experienced in the last 2 or 3 years. So diagnostically, I just wanted to say a few things about the testing that we have available. We have laboratory-based testing. We have tests that can be performed at home but sent to the lab for results, and we have tests that are performed at home and we can see the results at home. And there are two types of tests, the antigen test and the molecular test. The antigen test is the one that has been used so widely that you pick up at the pharmacy typically, and you just test yourself at home and get the results at home. The molecular tests are what are called nucleic acid tests, like PCR tests, and they're typically you can be tested. They're used at doctors' offices or at urgent care or the emergency room. You can get them at home now. The price of those have come down much more. Most of those are usually sent back to the laboratory for diagnosis, so it's delayed. But some of them that you can get at home now, you can actually perform at home. The antigen tests remain less expensive. But I wanted to talk about some of the important questions that I get in regards to the testing. And on the left-hand side, you see a graph that you don't have to spend really any time with, but I wanted to just illustrate where there are false negatives and how to interpret those. So the first point I wanted to make is that with COVID, you can be contagious and not have any symptoms. people are contagious. What you see on the left-hand side is what they call the pre-infectious period. It can be for up to 48 hours. Typically, it's about a day before you become sick. So when you can be contagious then, and the antigen test that we do is often negative when you're asymptomatic. When you're symptomatic, the antigen test can still be negative. There still are false negatives, but usually it's positive. So a negative antigen test does not rule out COVID. So if you're sick and you do an antigen test and it's negative, that makes it less likely that you have COVID, but it doesn't completely rule it out. A positive antigen test, on the other hand, if you have symptoms of COVID, it's almost always truly positive. So you've diagnosed COVID, you don't need any further testing. Now, in regards to a molecular test, a negative molecular test is so sensitive that if it's negative and you're symptomatic, your symptoms are due to something else besides COVID. You've ruled out COVID almost assuredly. The caveat about the molecular test is that after you're well, you can still have a positive molecular test that can go on for up to 6 weeks, some reports even up to 3 months, and you're not contagious. So there's no reason to you shouldn't do a molecular test after you've had COVID to see if you're still contagious, because it's going to be likely positive, but you're not contagious. On the other hand, the antigen test correlates pretty well with contagion. So if you've had COVID, your symptoms are now gone, and your antigen test is negative, it's highly unlikely you're still contagious. I wanted to just say a few words about treatment, and specifically about Paxlovid. Does it still work? Yes, it still is just as effective against Nimbus and Stratus, all the new subvariants, compared to how it worked earlier on. So yes, it still works. Does it prevent COVID? Maybe. The data is not very solid on that. Household studies of the index case, let's say a child comes home from school and has COVID, and if mom and dad or other kids in the home take Paxlovid, it does reduce the risk of getting COVID. But we don't know how well it's going to work. It works in that regard. So there are circumstances where it may be beneficial, particularly if somebody in the home is immunocompromised. Does it prevent long COVID? There's pretty good data that suggests that it does. If you get COVID and you take Paxlovid, the data suggests that it does reduce the risk of developing long COVID. Now, the data is not uniform. There are some studies that haven't shown that benefit, but most of the studies have shown benefit. So we think it does add to our prevention of long COVID. Does it treat long COVID? If you've got long COVID, does taking Paxlovid work? The initial trials of that, unfortunately, have been that it does not work. More recently, there have been some longer-term trials. That is, people have been given Paxlovid as opposed to 5 days. They've been given it for 10 days and sometimes 2 or 3 weeks. Those trials are pending right now, so we don't know. So the question, does it treat long COVID? It continues to be a question. And is there a drug better than Paxlovid? Not on the market yet, for treating people who are not hospitalized with COVID. But there are quite a few drugs in development in phase 3 trials. So there likely will be newer drugs coming out. And unfortunately with Paxlovid, it interferes with several drugs that we're taking, and you either have to modify the dose so that you may be taking of your statin, for example, or you just can't take it. There are a few drugs, not very many, where you just can't take Paxlovid. And if that's the case, there are 2 other outpatient treatments. Remdesivir, unfortunately, that has to be given at a facility that can give it to you IV, and you have to take it daily for 3 days. So it's quite a hassle. There's another drug called molnupiravir. It does not work as well as Paxlovid or remdesivir, but it is an alternative for those people who just cannot take Paxlovid. Paxlovid has been shown to decrease the duration of viral shedding in somebody with acute COVID, and it has also been shown to decrease the duration of symptomatology. So it's a drug that helps keep you out of the hospital, helps prevent you from going to the ER, certainly prevents dying, and gets you well a little more quickly and decreases the length of time you're contagious. So it's a good drug, but it's not used a lot, or not nearly as much as I think it should be. And these are just some of the reasons. It's costly, although for seniors, Medicare pays for it. Um, Availability is not as big a problem as it used to be, except in rural areas. The interactions are a big issue. If you have kidney problems of significance, that is, where you have significantly decreased kidney function, you'll either have to reduce the dose or not take it. It does have side effects. It gives a terrible taste in the mouth to a lot of people. It can cause nausea and sometimes diarrhea. So it does have side effects. But the two that I think are really bother me the most are people are worried about rebound, and doctors will often say, well, you don't look that sick, so why take it? Let's start with that. If you have COVID, the initial symptoms are due to the viral replication in your body and the beginning of your immune response to it. What Paxlovid does is it decreases viral replication. That's what all the antivirals do. Where people really get sick and wind up in the hospital with COVID typically is on day 7, 8, or 9 after COVID began. And that's because of an overwhelming immune response, a dysregulated immune response that causes so much inflammation in your airways primarily, but throughout your body, that you really are having trouble breathing and have to be hospitalized. So you can have COVID and not be very sick on day 1, 2, 3, 4, 5 of your symptoms, and then get really sick on day 6, 7, 8, or 9. So, and Paxlovid has to be given within the first few days of illness. We say first 5 days, but the earlier you take it, the better it's going to work. And nobody's able to predict who those few people are who get COVID, who are going to get really sick in a few days. So when the patient doesn't look that sick, that doesn't mean that they shouldn't be on Paxlovid if they're at higher risk for a bad outcome, particularly being older. So I don't think that's a criterion. I think a lot of doctors are making that mistake. The other issue is rebound. The best studies we have on rebound show that rebound occurs just as commonly after you take Paxlovid as it would if you didn't take Paxlovid. Now, there are some studies that were done in very good places, one at UCSF and other at Stanford, that suggested that rebound may be a little more common if you take Paxlovid than if you don't. So I'd say that the best studies suggested that there's no difference, but there are studies done by good people that suggest that maybe there is more rebound from taking Paxlovid. Rebound is almost always less severe than the original case of COVID and almost never more severe. So I don't think that that should be a reason for fearing to take Paxlovid. So let's now talk about prevention. This is the Swiss cheese defense that people have talked about now for several years. I talked about it with Ashby Village 2.5 years ago. And it's just the idea that on the left-hand side, you see the virus there in green, and to get through to the person on the right-hand side, it has to go through all the holes. And if the holes aren't lined up, it's going to get blocked. So it's not like there's any one defense that's going to be perfect, but if you have lots of different defenses, they're going to make it very difficult for the virus to get to you. So physically distancing from people, staying home if you're sick, wearing a good mask to prevent you from inhaling the virus, Hand hygiene, maybe we don't think that the virus is likely spread very often by hands, but hand hygiene always remains a good idea. Cough etiquette, avoid touching your face because we are always touching our mouth, nose, or eyes. If you're crowded, limit your time in a crowded place if possible. Certainly wear a mask if you're in a crowded place indoors, and so on. I think all these things we've talked about and you've read about ad nauseum. But I want to really focus on the last piece of the slice of the Swiss cheese, and that is the vaccines. So this charts out all of the vaccines we've had through last fall. And last fall are the current vaccines that are available. So these are all the vaccines that have been offered to us. The first one came out against the ancestral strain. And then the second one came out that was bivalent, contained the ancestral strain plus another strain, and so on. You can see about that. So we've had 1, 2, 3, 4, 5, 6 different vaccines. When I say different vaccines, excuse me, they're really the same vaccine. They're just directed at different structures on the spike protein of the virus. The three vaccines that are currently available are Pfizer's mRNA vaccine, Moderna's mRNA vaccine, and Novavax protein-based vaccine. And I'd like to say a few words about these three. Pfizer's vaccine, the 2024-2025 vaccine, this was mRNA that was directed against that KP.2 variant of Omicron. The 2025-26 vaccine probably will include the mRNA for the spike protein for JN.1 or LP.8.1. I'm saying probably for reasons that I'll explain in just a few moments. Moderna's mRNA vaccine, there are two versions of this that were approved as of June of this year. Not the older version, the version that we're familiar with is called, the brand name was SpikeVax. This is what we received last fall. And for those of you who got a booster 6 months later, that's what you received. That was directed against Omicron's KP.2 variant. In the 25-26 version, we think it will contain the messenger RNA to code for the JN.1 or LP.8.1 variant, just like Pfizer. Now, Moderna's also come out with an approved vaccine called mNEXSpike. And this vaccine contains less mRNA than SpikeVax. It contains mRNA that is directed at small components of the spike protein as opposed to really the whole spike protein. And it was licensed in May of 25, and it will also be directed against JN.1 or LP.8.1. It may be, and I'm really underlying maybe, more immunogenic. That is, it may, even with a smaller amount of RNA, messenger RNA, it may give us a better immune response. We won't really know until after we have data from the first round of the use of this because we only have preliminary data. But that's tantalizingly exciting. It's also has the advantage of does not require the real cold temperatures that the mRNA vaccines previously required. It requires refrigeration, but not real cold temperatures. So that really improves logistics. So we'll keep an eye on mNEXSpike. And finally, Novavax, the 24-25 vaccine, that contained an mRNA against the JN.1 variant. And its approval has been changed from everybody 12 and over to now people 65 and older, as well as individuals 12 to 64 who have underlying conditions. So it's had its range restricted by the FDA's decision several months ago for reasons that, frankly, I think are inexplicable. All right, so that's what's available to us. I want to look at the process of how we come to the decisions of what's going to become available. And in February of the preceding year, so in February of 2024, for example, looking at last year, that's when the FDA and the World Health Organization typically determine what the vaccine formula will be for the following year. And then the manufacturers start to manufacture it in the spring. The Advisory Committee for Immunization Practices, ACIP, this is the advisory committee to the CDC, determines who will get it. And this is signed off by the head of the CDC or the HHS secretary. That typically occurs in late spring. By summer, the insurance companies have determined what they're going to cover based upon what ACIP has recommended and the CDC director signed off on. Health clinics will order the vaccines, and the vaccines that are licensed for approval are available in the fall. This system has been going on for all vaccines for decades and has worked very, very well. And it puts us in good stead for being where we want to be in the fall. So that's what happened in 2024 and the preceding years. But three things happened in 2025. One, we know about the federal workforce cuts. I'll talk more about that. We know about budget reductions and funding disruptions. I'll speak more to that. And we know that the federal leadership currently is ideologically opposed to vaccines in the established system of approving them. And I'll definitely talk more about that. So, in terms of workforce cuts since January 20th, 2025, these are all approximations because, as you know, that the data has not been very forthcoming. I looked at the CDC, NIH, and FDA data. The numbers next to those institutions reflect the number of employees as of January 1st of this year. If you just I don't want to go through all these numbers with you, but if you look at the estimated net loss of employees, the CDC was very few, not well, it was 120 out of the 14,000 employees. NIH had between 1,000 and 1,200 employees that have been gone, that are gone, and about 700 from the FDA. These are just people who are forced out, fired. This does not include the large number of people from these institutions that quit. If we look at budget reductions and funding disruptions, the NIH has cuts. They had initial proposed cuts of $3 to $20 billion. The actual or realized reductions as of a week ago were between $2 and $8 billion. And the judge voided a little more than $1 billion. So those have been reinstituted. So in terms of funding, you can see that there have been big cuts to the NIH. To the CDC, it's about the initial proposed were about 1.2 billion. Much of that has been mitigated by the Senate. The FDA proposed cuts were about 855 million. We don't know where that stands. And in terms of the federal leadership being ideologically opposed to vaccines and the established system of approving vaccines, a few comments. The federal agencies are no longer aligned at all. What the FDA has been saying does not align with what we hear from HHS, Human Health Services, which the CDC and the NIH are under, as well as the FDA. There's still no national recommendations on who should get the updated COVID-19 vaccines this fall. Typically, always by June, throughout the pandemic, always by the third week of June, the CDC had made recommendations on who should get the updated vaccines. It is now August 14th. We still do not have national recommendations. The Advisory Committee on Immunization Practices, which I'll have more to say about in a moment, was supposed to meet this month to advise the CDC. There is nothing on the schedule for it to meet. So I don't know if we're going to have national recommendations on who should get the updated COVID vaccines this fall. So I'm only going to be able to give you some approximations in a few moments. Insurers at this moment in time have no idea who to cover. Doctors are unsure who to prioritize in terms of getting the vaccines, and pharmacies are uncertain about the number of doses to be given and whether their staff can administer them. Everything is
Recording stopped.
So everything is up in the air. I don't know if you heard, but it said the recording was stopped. If somebody wants to record, they should start that again. So here's the same thing that I showed you before. This is from a terrific Substack by Caitlin Jetelina, an epidemiologist, called Your Local Epidemiologist, or YLE. And really what this is showing, I won't read all of these aspects to you, but what it's showing is how the system has been dramatically perturbed from really the very beginning of the current head of the HHS in his tenure. So that's why we just have no idea where we stand right now. So I get a lot of questions about the vaccine availability. Will I be able to get the COVID-19 shot this fall? And if so, when? My guess is that yes, we will be able to get it. It may be more difficult to get just because of all the confusion, but it should be available. Will insurance cover if you're not at a high-risk category, if you're under 65 and in reasonable health? And the answer is we don't know, but anecdotally, I've heard from many insurance companies and people who have talked to insurance companies, and they're all likely going to cover people at high risk. I've heard, I haven't seen in writing, I've heard, for example, from Anthem Blue Cross and Blue Shield of California that they will be covering it for people at high risk. Can you get it off label, meaning can your doctor prescribe it even if you're not in the high risk category? And the answer is I don't know. And will pharmacies and doctors even have enough supply? I suspect they will, but you can imagine if you were a pharmaceutical executive, how much vaccine do you want to produce? And if you're a pharmacy buying it or a doctor's office buying it, how much do you want to buy? All of these problems are self-inflicted. So here are the current COVID recommendations, looking at what the FDA has approved, but still not having the CDC's imprimatur. The old recommendation for people over 65 is get a COVID vaccine if you've not received one, and get boosters when your doctor recommends, which for people over 65 and certainly over 75 would be every 6 months. The new proposed recommendations is they have not currently changed, but again, we don't know how they may change. For people 18 to 64, the old recommendation was get a COVID vaccine if you have not received one and get an annual booster. The new proposed recommendation is a COVID vaccine or booster is not needed. I disagree with that. For people 18 to 64 with underlying conditions or a condition, get COVID vaccine if you've not received one and get an annual booster. The new proposed recommendations have not been changed. I don't think they will change. If you're healthy children 6 months to 17 years, the recommendations up until very recently were get a COVID vaccine if you have not received one and get an annual booster. The new proposed recommendations are parents should consult with their child's pediatrician in a, quote, shared clinical decision-making process. which translates to you should talk to your pediatrician and get his or her advice as to whether you should get it. It means it's not recommended. And that word recommended is pivotal because if the CDC does not recommend a vaccine, insurance companies do not have to pay for it. There may not be an approved vaccine for healthy children 6 months to 5 years. Pfizer had authorization to do that, but just last Friday, the CDC sent a letter to Pfizer saying they're seriously considering not approving the vaccine for children 6 months to 5 years. Please remember back to what I showed you in terms of the state of the pandemic, in terms of young children, especially children less than 1, and their mortality and morbidity rates. And it's very likely that there will not be an approved vaccine for them. Also, I'll speak to later, but the vaccine is no longer approved for people who are pregnant unless your doctor advises it. And the major reason for getting the vaccine if you're pregnant is that in pregnancy, you're somewhat your body is immunosuppressed, so you don't reject the fetus. And we know that pregnant women have higher morbidity and mortality than other women their same age. The other reason we urge pregnant women to get vaccinated, particularly in the 3rd trimester, is because the antibodies that mom produces cross the placenta and go into the fetus. So when the fetus is born, the fetus has mom's immunity to COVID, because we can't vaccinate children until they're above 6 months of age because the vaccines don't work well. So the only protection those infants get is mom's immunity. And remember again what I was saying about children less than 1 year of age and how they're hospitalized at a much higher rate and how they die at a much higher rate than other children. So pregnant women, I was just talking about that. The old recommendation is that all pregnant women should get a COVID vaccine or booster. The current recommendation is it's no longer needed. Kennedy came out and said on X, he said he was proud to announce that the vaccine would no longer be needed for pregnant people. So let's talk a little bit about what's happened since February 13th, when RFK Jr. became the director of HHS, appointed by the president. As of today, he's been in office 182 days. And I'm going to take the liberty of just showing you not everything he's done in those 182 days in regards to vaccines, but a lot of what has happened. On April 15th, there was a very well-known, highly respected researcher and physician at CDC named Fiona Havers. She presented her data to the ACIP in April. That was the ACIP that had been same members, the 17 members, all vaccine experts. She resigned a month later for reasons that I'll show you. On May 17th, the FDA approved Novavax's COVID-19 vaccine, but only for older people and those at high risk. In other words, it was previously approved for everybody 12 and over, and now they restricted it. On May 20th, the FDA outlined its stricter COVID vaccine booster approval standards for healthy people. They said that they wanted double-blinded, controlled, placebo-controlled studies. Those are very good studies, and we always do those for new vaccines, but we don't do those when we're just changing the composition to cover how the virus has changed. For influenza, we've done this for decades, and we don't do double-blinded control studies when we just make minor tweaks in the vaccine. Furthermore, to do a double-blinded controlled study on a vaccine against COVID when it's constantly evolving means that by the time that study was done, the studies that it was done to protect us against those strains of the virus would have been long gone. So it's completely, well, it sounds good to the public, but it is antithetical to the public's health. On May 21st, Moderna had to, they quote, voluntarily withdrew the pending BLA, the biologic license application for its flu COVID combination vaccine for adults 50 years and over. And the reason why was because the FDA had informed them that they weren't going to approve it. And all the data that they had that had been published was quite encouraging. It would have meant going in and getting one and done for a lot of people who didn't want to get 2 shots. On May 27th, the COVID vaccines would no longer be recommended for healthy children and pregnant people. I talked about that. On May 27th, also, RFK Jr. threatened to bar government scientists from publishing in leading medical journals, for example, The Lancet and the New England Journal of Medicine. On May 29th, there was a report on children's health. This was released by the MAHA Commission, put together by Kennedy. This report was filled with canards and false references, and at least one reference didn't exist. On May 29th, also, HHS canceled Moderna's candidate H5 vaccine for avian flu. This was a $766 million funding to produce for us a vaccine that could protect us if there was a avian flu pandemic. The following day, HHS canceled $258 million to the National Institute of Allergy and Infectious Disease AIDS Research. On June 9th, RFK fired all 17 members of the ACIP. You probably read about that. On June 12th, 3 days later, after not going through any kind of vetting process, let me pause and just tell you that for somebody who wants to become a member of the ACIP, the vetting process takes typically about 8 to 12 months. They're so carefully vetted. RFK appointed 8 new members with 3 days of vetting process. One of them had to drop off because he had financial conflicts. So there were 7 new members. Only one of those 7 had any expertise in vaccinology and public health. Several of the appointees had publicly expressed skepticism of vaccines and several of them had been involved in lawsuits against vaccines. So essentially, he appointed an advisory committee to the CDC that was all anti-vax, except for one person. And none of them had any expertise in vaccinology or public health to any extent. 6 days later, RFK directed his newly appointed ACIP to evaluate aluminum-containing adjuvants in vaccines. Adjuvants are like aluminum, are put in the vaccine because you get a much better response to them. They're not, and they've been used for decades. The anti-vax movement has been vociferously against aluminum in vaccines as an adjuvant. We've had plenty of studies, include one that came out just 2 weeks ago, done in Denmark, that have shown absolutely no risk to the addition of aluminum to these. On June 25th, RFK cut funding to what's called Gavi, the Global Alliance for Vaccine Initiative. This supports vaccines for more than half of the world's children. The United States piece of Gavi was about 17% that Gavi no longer has. Gavi started in 2000, and it's been estimated to have saved the lives of at least 20 million children, and RFK cut that funding. On July 31st, HHS barred 8 professional medical organizations from participating as outside liaisons to the CDC's Vaccine Advisory Committee. Infectious Disease Society of America, American College of Physicians, American College of Obstetrics and Gynecology, American College of Family Practitioners, just to name a few, 4 of those 8 that were banned from advising the CDC. On July 28th, the director of the CDC, excuse me, that's a typo. So I'll go to July 31st. HHS barred 8 professional I repeat that. So there's some typos on there. So disregard those last 2 red bullets. Almost through. On July 7th, the American Association of Pediatrics and several other societies filed a lawsuit against RFK Jr. and HHS, arguing that the current policies on COVID-19 vaccines pose an imminent threat to public health. On July 24th, HHS ordered thimerosal out of all flu vaccines. Thimerosal was put in multi-dose vials of vaccines to kill any organisms that would get in. When you go into a vial more than once, there's the possibility of introducing bacteria. And before this was used, people got bad infections, some very serious, from multi-dose vials. So thimerosal has prevented all of that. There's been no study that's been done that showed any problem use of thimerosal, and there have been a lot of studies. It doesn't have really much of an impact here in the United States because only around 4% of the flu vaccines are multi-dose vials. All the flu vaccine that almost all of us get are from single dose. But worldwide, multi-dose vials are critical, and it's going to be difficult. This is going to make it difficult for manufacturers to produce 2 types of vaccines that are multi-dose. So it will have an impact worldwide. On August 5th, RFK terminated 22 mRNA vaccine research projects worth about $500 million. On July 24th, HHS ordered thimerosal out of all the flu vaccines. I mentioned that. On August 5th, I mentioned that. On August 8th, you probably remember it was last Friday that a man fired 500 rounds with 200 bullets hitting 6 CDC buildings. And the intention was that he wanted to kill the people that were producing the mRNA vaccines. And that same day, the FDA signaled that it might not renew Pfizer's emergency use authorization for COVID-19 vaccine for children 6 months to 4 years. I mentioned that. I know that was a lot, but I wanted to just show you what's happened to public health just with vaccines. And vaccines are a microcosm of all the other things that are being done to our government. So vaccines, conservative estimate over the past 50 years have probably saved 154 million lives. But in the United States, both access to vaccines and public trust in them are being systematically undermined, as I've shown you, not only by conspiracy theorists, but from within the highest levels of our government. So are we prepared for the next pandemic? Well, we weren't very well prepared for COVID, and we are far less prepared now with, frankly, incompetence at the highest levels of government. So the pandemic clock is ticking. We just don't know what time it is. We've had 3 pandemics in the 21st century, roughly one every 7 years. SARS, in 2001, 2. We had influenza H1N1 in 2009, and now we have COVID. So there's surely going to be another pandemic, and it may be just around the clock, or it may be a little bit longer, hopefully the latter. So I'll conclude with this quote from Jonathan Swift in the 18th century: "Falsehoods flies, and truth comes limping after it, so that when men come to be undeceived, it's too late. The jest is over, and the tale hath had its effect." Okay. Happy to take questions. Sorry to leave you on a downer, but it's very hard being in public health today.
I have a question about whether you think it's advisable for an elderly person who has no discernible immunity by titer to measles to get a measles vaccine.
Yes. So I'll sort of dilate on that. The CDC has for a long time said that if you were born before 1957, you could assume you've had measles. And if you've had measles, you're going to be immune the rest of your life. In 1963, a measles vaccine was approved for use and was used in the United States. It was taken off the market 5 years later because it was not very effective. But a lot of people may have got between 63 and 68. In 1969, the new measles vaccine was released, and that's really essentially been modified just a touch, but that's what we've been getting ever since, and that's the one that works so well. If you get the 2 shots of that vaccine, it gives you 97% assurance you will not get measles.
Mm-hmm.
So I was a relatively new doctor in Berkeley in 1970. It was 1976. I'd started in Berkeley in 75. And I was just around 30 then. And a patient came in who was about my age. And I examined her, and she didn't have a rash, but she had these characteristic changes in the inside on her, what's called the buccal mucosa on the inside of her mouth. Only measles causes that. And I looked in there and I saw them, and she was really miserable. She had 103 fever, her eyes were red, and she was just really sick. And I told her that tomorrow she was going to break out in a rash. And she did. And I was really proud of myself for diagnosing measles, which any doctor in the generation before mine could have easily diagnosed. And then 12 days later, I came down with measles. And I was born long before 57. And my daughter, who had been immunized, and she didn't get it, but my son hadn't been. He was too young, and he got it from me. And my wife, who was born before 57, well before 57, she got it from me. So I've never trusted the CDC's statement that if you're born before 57, you can assume you've never had measles. Sorry for going on about that. So that's why I think that if you're unclear whether you've been vaccinated or not with the good vaccine, the one that began in 69, if you're unclear about that, and you're unclear or you're just not sure you've had measles, then get a titer, a blood test like you're talking about. And if that's positive, it means you're immune and you don't have to get vaccinated and don't worry about it. If it's negative, I'd get vaccinated.
Is it the same vaccine for adults as for children that you would get?
Mm-hmm.
Okay.
Now, the only reason for pausing on that is we have 40 million people in the state, and we have the lowest percentage of cases of measles in the United States. And that's because we have some of the highest vaccine rates in the United States against measles. So the risk if you're staying here in California is really low for getting.
Yeah, I'm in Washington actually, but
well,
I don't know.
Washington State,
Yeah.
their vaccine rates are pretty good, but I wouldn't travel to Texas.
I wouldn't anyway.
Okay. Or the 40 other states that are having significant outbreaks of measles.
Right.
So yeah, I'd get vaccinated.
Dr. Swartzberg, Marlene asks if COVID test expiration dates are valid. We've been told that they are probably okay longer.
Yeah, they are and they aren't. How's that? They are valid if you test yourself and it's negative, you can't count on it being negative. It may be because it's expired. If it tests positive, it's positive. So it's like taking a medicine that's expired. It probably is still going to work, and it probably will work okay. But you don't want to take a chance on that. But if the test turns out positive with the COVID test, then it's working. And so you've got COVID. But if it comes back negative, it could be falsely negative because it's expired. Bottom line is I'd use something that's not. What I would do is I'd go and test myself with something that's expired, and if it's negative, then I'd go buy one that's not expired and use that. If it's positive, I know I have COVID.
What about Paxlovid? It apparently has a pretty short shelf life, 10 months or so.
It has a really short shelf life.
Yeah.
There, it would be, I would not take it.
Okay.
I mean, if I would get Paxlovid that has not expired. If you're somewhere where you can't get Paxlovid and all you have is the expired, I would take that. But if you're a candidate for taking Paxlovid, I would take what you know is going to work. It's like don't find some antibiotics in your shelf that when you get sick, you just start taking even if it's expired. On the other hand, if you've got aspirin on your shelf and it's expired, take it if you're taking it for a headache.
Any other questions? Just Sally, go ahead, unmute and.
Okay. Yes,
There you go.
this is off topic, but I had all three shingles vaccines, and I still got a terrible case of shingles.
Well, you had bad luck. I'm
Yeah,
sorry.
I guess. I mean, is it possible the vaccine wasn't any good or what?
Yeah, the vaccines,
Joke.
the first vaccine you got was protecting somewhere between 60 and 80%, prevented 60 to 80% cases of measles. The new vaccine, those 2 doses of the new one that you got, which is much better, is giving 80 to 90% protection. So you fall into that 10 to 20% group. That it just didn't work as well. Was it a bad case of shingles?
Yeah, it was bad. I had a couple of blisters. I went all the way from my spine, all the way under my arm, up over my left breast to my sternum.
Mm.
And it was extremely painful. I've never felt anything like it. I had no idea it could hurt that badly. And it took a couple of weeks for it to resolve. And they made me isolate where I live because they thought I might be catching. Now, I had shaken hands with a man who later on I found had shingles. Can you catch it from someone? I thought you had to. It was a result of having had chickenpox.
Yes, the latter is true. Shingles is a reactivation of the chickenpox virus you got typically as a child that's never left your body and then reactivates later in life.
Yeah, so I couldn't have caught it from this person.
No,
Yeah,
but
okay. Well, I didn't think I could have,
it's
but it
somebody.
was coincidental.
If you've got shingles, somebody could catch chickenpox from you if they've never had chickenpox.
Yeah, yeah,
I'm really
right.
sorry about shingles. The vaccine is really good and it really works well, but it doesn't cover everybody. You know, the
Is
best.
there a long shingles? Because the whole area where I had it, which was in April, is still sensitive, burns, itches.
Yeah, it's called
But they have long
post-herpetic.
shingles.
They call it post-herpetic neuralgia,
Yeah,
and it can last months and sometimes years and sometimes never goes away. But most of the time, it'll last a year and goes away.
wow.
We had a follow-up question from Marla about, are there some people naturally immune to COVID? Or is that even possible?
It is possible. We don't know. We probably won't know for a long time, but there probably are some people who are naturally immune. I say that because our immune system it's an incredibly complex system, and it is, and as long as there's a lot of genetic variability in a population, whether it's humans or any kind of life form, it gives us the opportunity, it gives a subset of the population a chance to survive by having certain qualities. For example, there are very few people on this planet, but there are some who are immune to getting AIDS, HIV.
Hmm.
So it can happen. Most people died of the plague who got the plague in the 14th century died, but there were a subset of people who were relatively resistant to the plague. So that has happened with all infectious diseases, and there's every reason to think there are some people who won't get COVID. We don't know how to identify who those people are, so I wouldn't assume that you're immune to it.
Dawn, what about getting COVID vaccine more frequently than every 6 months, say every 4 or 5 months?
Well, the current approval allows people to do that. You can get it after 3 months. And if you're immunocompromised, you could get it as often as every 2 months. I think that what we know in terms of vaccine protection in people who are otherwise healthy, older people like us, is that the immunity wanes, and it wanes fairly quickly. So you've got really good protection in a month after the vaccine, 2 months after the vaccine is still good, 3 months it's still pretty good, 4 months it's still pretty good, but not quite as good as 3 months. And by 6 months, it's not, I mean, we still have some protection, but it's not nearly as good. So that's why we recommend for people at higher risk, roughly every 6 months. But you know, if you got it 4 months ago and you're taking a big trip, then I would probably just go ahead and get it before you travel. Or if there's an occasion that's going to be high risk for you, but you just don't want to miss it, you know. So you've got some malleability in this system.
So is there a current shot available?
Yeah.
So you just have to see if your pharmacy has it and make an appointment.
It's available. I've heard anecdotally where it's a little more difficult to find. You may have to call around to different pharmacies.
I think you covered whether long COVID is contagious, but is it, and can it be tested for?
Donna had a question, I think.
Oh, I'm sorry, Donna. You want to unmute? Donna? Yeah. Thanks, John.
Okay, so I'm wondering about Kaiser, like, for example, just what Sarah just asked. If I wanted to get a vaccine sooner, do you think the Kaiser would allow it? Do you have any idea?
I don't know. But what I would suggest doing is contact your doctor at Kaiser and explain why you want to get it sooner than 6 months, and have she or he tell the pharmacy.
Okay. Okay.
I think Helene has a comment on that.
It so happens that yesterday I asked my husband's doctor if he should run in and get a COVID vaccine. And he said, no, wait till the new ones come out in September.
That's right. That's what I would say. But there's still a question mark of when those new ones are going to come out. And I'd hate to see somebody who's past 6 months, who's older, so at higher risk, to wait another month or two to get their vaccine. When we're in a period of increasing cases of COVID in our community.
Well, that's us.
I know.
Last vaccine last November.
Yeah. Well, that's a judgment call. I think what I would do if I my last vaccine was last November, I'd get it now because there's a lot of COVID in the community. Actually, thank you for asking that, because it reminds me of something I meant to say in my talk, and that was that I showed you that how the virus had evolved, but how the cluster of all these variants are pretty similar. They're genetically very related. Well, we have lots of studies now in the lab that show that the vaccine that we got last fall or 6 months ago, or would get right now, likely is going to work as well or almost as well as the new vaccine that's coming out. So it's not like the new vaccine is going to be so much better. It may not be any better, or if it's better, it's probably not going to be much better. So keep that in mind when you're doing your calculus.
Jane has a question for you that I thought was very good. Do you want to unmute, Jane?
Okay, so we've lost the people that study vaccines for upcoming illnesses, etc. And we've lost muscle and all these federal health groups. Are any other countries stepping up to take leadership so that the research continues and the gains that we've made can go forward?
Yes, there are lots of countries, primarily in Western Europe, although not exclusively, that are picking up some of the slack. But you know, the United States has been the leader for so many years, and the slack that's going to be picked up by these other countries is not going to compensate for what we've lost here. Some of the slack that's being picked up is the European country, several European countries and Australia and New Zealand and Hong Kong and Singapore, to name those that I'm familiar with, are all actively recruiting American researchers. This government is making a concerted effort to destroy public health.
But will we be allowed to buy the vaccines from the countries?
Well, remember when vaccines were first released in 2000, Americans were first in line.
But there will be tariffs on those vaccines, right?
Yeah, there will be.
And I had a quick step back. Where is the measles shot we talked about? Was that the MMR, measles, mumps, rubella?
Yeah.
Yeah, you get it all as a
package.
A package deal, yes. I was first in line when they came out, so.
They even have MMRV, which is mumps, measles, rubella, and varicella, chickenpox.
Oh, great. So it's all in there now. Ooh, even better. More questions? We've had a amazing crowd today for you, and your talk was so interesting. I'm sure we'll think of lots of questions later on. Do you think there's anything we can do about the situation in Washington as far as public health specifically, vaccines specifically, I mean, your lobby, the physicians lobby, American, physicians and all those, are pretty strong, I would hope. And yet here we are. So do you have any thoughts on that subject besides standing down at Broadway and 51st with signs?
Yeah, as well as you probably have better ideas than I have. I'm surprised that there's not more protests. What's going on is absolutely catastrophic. But one of the reasons for showing you what RFK has done since February 13th is it's like drinking from a fire hose. It's like you respond to one thing and then there's just the next day there's more egregious things coming out. And the same thing could be said from the White House too, for that matter. So it's almost numbing people. I'm dumbfounded by why people aren't in the streets.
I know some of these folks have been.
Good. Keep it
but
up.
I think, it gets a little tricky at times just to wonder if that is the way to go about it, or if there are multiple ways that we can.
Oh yeah, sure. I mean, the
better.
usual things is write to your congressman. It does help.
Yeah.
Phone calls and all the usual things that people talk about. If you belong to a professional society, become more active in that society to put pressure. The same thing. What's happening in public health? Look at what's happening in universities right now. And I could go on and on, but I never thought I'd see the day when we'd see universities buckling to the government like this. Of course, I never thought I'd see the day when the government would want the universities to buckle.
A friend at Vanderbilt just told us that her project with CDC did pass somehow through a little loophole, but that the whole department is gone all around her, except for about 5 of them.
Well,
So they're doing their best to hang on.
yeah.
Tara, I think we have a question from Tricia. Tricia,
Yes.
you want to unmute?
Yes, can you hear me?
Yes.
Yes.
Yes, I got COVID. I got a positive reading today.
Oh.
And my
Oh.
question is, because I have COVID now, do I need to get another vaccine for another 6 months, or am I now have that immunity?
Yeah. Well, first of all, make sure get on Paxlovid as soon as you can.
I'm on it. I just got on it. It took me all day and
Okay.
5 different people.
Good work.
Yeah.
It shouldn't be that hard. The answer is yeah. You're gonna have a robust immune response. It's like getting vaccinated.
Okay. Thank you.
Yeah. Get well quickly.
Thank you. Yeah, I'm 74 and it's not easy.
Fine. I've got a question. Can anyone hear me here?
Yes,
or-
go ahead,
can.
Rodney.
Yeah. This is more of a statement, I guess. Experience I had. The participant who was mentioned Kaiser. I'm also a Kaiser member, and this happened to me 3 times, where I would get an email from Kaiser saying, "Okay, Mr. Ricks, it's time for you to come in for your COVID vaccine shot." And I'd say, "Okay, great," and I'd make an appointment and come in, only to be told by the nurse, "No, we can't give it to you. Just flat out cannot give it to you." And I would leave very frustrated and confused. And then finally, the 3rd time it happened, I just stayed there in the clinic, and I'm not leaving until I get my shot. And I finally kind of stared them down, and they brought out some kind of a form that I needed to sign. I don't recall what was on the form, which I signed, and I got the shot. That was about 6 months ago. So I guess technically I'm kind of due for another shot now, but I'm just kind of wondering at this point, what kind of a response I'm going to get when I try to get another shot there. It was a very mystifying, frustrating experience. And I never got to the bottom as to why one hand apparently didn't know what the other hand was doing. Very frustrating.
I'm sorry you went through that.
Yeah.
It's been 5 years. You'd think that would be enough for people to really have all of this worked out, but the reality is our systems are still trying to catch up, and
Yeah.
we're not working optimally. They haven't worked optimally throughout the pandemic. So Kaiser's been a good source of of delivering public health.
Yeah.
Like any organization, sometimes the right hand has no idea what the left hand's doing.
It's a huge organization, and I just keep telling myself, you've got people. Organizations are made up of people, and people are notoriously not perfect, and so things get messed up. Yeah. Okay.
Good luck next time.
Thank you.
Mary Dexter, do you want to give your comment? I don't know I will read her comment. UCLA just got research.
Right. I can read it. We can't hear you.
Back. A judge declared sorry.
You were
and then Jane had another comment too. Jane?
So what do you recommend about masking currently?
Yeah. What I'm doing, actually, my wife, just before I started this talk, was leaving, and she asked me, should I wear a mask where I'm going? So we all have the same question. What I'm doing is, if I'm outside, I'm not wearing a mask. If I'm inside and there's not many people around, I'm not wearing a mask. But if I'm inside and it's lots of people in public, I'm going to put a mask on. If I'm going on BART, I went on BART for the first time just a couple of months, about 6 weeks ago, and there were only 2 people on that train in the middle of the day, so I didn't wear a mask. But typically, if I'm going to a place like BART, I would wear a mask. So it's that, again, that Swiss cheese defense, trying to make a judgment as to limit your risk if you can. So indoors is risky, outdoors tends not to be. Indoors with lots of people, riskier than indoors with fewer people. But maybe I'll answer it in one other way, and that is I'm a little more careful today than I was 3 weeks ago.
Yeah. Okay.
And Jenny had a question, and then Charles had a question.
Can I ask my question now because it's in follow-up to yours? I'm sorry to interrupt, except that I have been misinformed about masks all this time, apparently. My understanding was that masks protect other people and not very much protection to the wearer. And I just wonder if you could comment on that.
Sure. Masks, most any mask you wear will offer protection to other people.
Yes.
So a surgical mask, the blue masks you wear, that offers protection to other people. Not 100%, but it really limits the risk to other people if you have COVID. If you wear an N95 or a KN95 or a KF94, those masks protect you. They'll filter out 94 or 95% of all viral particles that you would inhale. They're not going to be 100% because they often leak around the side. The N95 is the best because it doesn't leak as much. So they're not 100%, but they offer considerable protection to the wearer from catching COVID. So when you go to the store, I went to visit somebody earlier this morning in a rehab hospital. And there was a nurse there wearing a mask, but it didn't cover his nose. And then wearing a blue mask, the surgical masks, and those aren't going to offer them protection from catching COVID. They'll protect other people.
Okay.
Jenny, you had a question?
Thank you.
I have a comment. It says I never go in an elevator without a mask, and I don't shop without a mask. And I use my key fob to push the elevator button. I don't do this.
Yeah, well, again, we're not sure how important.
I haven't gotten it.
Yeah, good. Good, but you got shingles. We don't know how important hands are. I think hand hygiene makes sense for a lot of reasons independent of COVID, and maybe it'll offer a little bit of protection against COVID. So I know that Jenny had a question, or I think
I did. The question is administrative, but how do we access this recording for those in La Miranda Village who we would like to send it to? I was also thinking of sending it to my congressman. So how am I going to do that?
And I can answer that. To access the recording over the weekend, someone will put that on the Ashby Village website. So maybe check it come Tuesday or Wednesday or Thursdays. Since Hillary is gone, I'm not sure, Craig, whether you would do that or somebody at the office. So check midweek. When you go to the website, you don't have to log in. You don't have to be a member. The upper right, there's a big red rectangle that says YouTube. Click on that, and with a little scrolling up and down, you should be able to find this and pretty much all previous presentations.
Very good, because I think it'll be useful for friends and family, but also I want to share it with the village for sure. La Miranda Village, that is. Thank you.
Okay, well, thank you all very much.
Thank you.
Okay, well,
You're very generous with your time and wisdom.
Dr. John, thank you for this. It was both illuminating and sobering. It's perhaps the way I would put it. We do appreciate you coming back after, we missed you in the last couple of years. Thank you for giving us this update and sharing your valuable time with us
You're
today.
welcome. It's my pleasure. Thank you. Bye, everybody.
Good night. Bye, everybody.